So thank you everyone for being here. We're really excited to host you. Today I have a wonderful panel to introduce. We are talking about navigating long COVID with long COVID disability and understanding lived experiences of folks. So here I'll pass it to Grace and Nija and they will take it off. If anyone is running into any tech issues, just feel free to drop it in the chat and I'll help you. Thanks.
Thanks so much, Guyan. So as she introduced myself, I'm Grace Lam. I'm a adult respirologist and assistant professor at the University of Alberta and the co-director of the Edmonton Long COVID Clinic. My partner in crime this morning is Dr. Nisha Bakshi, and she is a general internist at the Royal Alexandra Hospital in Edmonton. And she also has a private clinic where she sees patients with long COVID. A quick housekeeping issue before we start. Any questions, please direct them to the chat, and Nisha and myself will be monitoring the questions and will be bringing up the questions and direct it to our panelists as we go on. So without further ado, we would like to start off the session with some basic definitions so that everybody attending will have an understanding of what we're talking about when we start to throw around some these very pertinent medical terms. Nisha.
Thanks, Grace. So we're going to just do some very basic definitions of what long COVID is for those of you that are listening or watching this later on. You may have met somebody with long COVID, you yourself may have had long COVID, but it's important to recognize that long COVID actually comes as a very broad terminology. Very briefly, long COVID simply is the idea that you have unexplained or unresolved symptoms about 12 weeks after your acute COVID infection. This timeline varies from jurisdiction to jurisdiction, but that is probably the most widely accepted timeline. And the number of symptoms that you can have as somebody who is suffering with long COVID is quite large. I believe that the Public Health of Canada at one point had a list of over 200 different symptoms that people with long COVID may be experiencing. I'm going to go through just a very kind of top level, some of the few things that we see on an ongoing basis in our clinic, and our patients with and our co-presenters with lived experiences will be able to talk a little bit more about what they experience as well. But some of the big symptoms that we tend to see, and I'll put them in categories, are cardiac or vascular, neurological, and immunological. When we talk about cardiac or vascular, you may hear people talking about having chest pains. They may talk about having palpitations or even having blood clots. So many of our patients with acute COVID and sometimes with long COVID do have chronic blood clots that they experience in their lungs or their legs. We may have patients who develop strokes after the fact as well. From a neurological perspective, lots of patients will experience things like peripheral neuropathy, which is numbness and tingling of the hands or the feet. They may have electric shocks that go through their entire body. We talk about central nervous system as well. So this is things with the brain. So brain fog, you may hear commonly referred to, and brain fog is a very, very broad terminology, and each individual patient will have their own description of what this means, but it can look like word finding difficulties. It can look like trouble with recall. So being able to remember or try to say what you were just thinking 2 seconds ago. It may be things with comprehension or retention, so not being able to follow along a text or conversation, as well as feeling overstimulated. So being in crowds around lots of noise and people and lights may be very difficult for patients with long COVID. One of the biggest things that we see in many long COVID patients is something called autonomic dysfunction. And so autonomic dysfunction is the idea that our sympathetic nervous system, our fight or flight and freeze system is overactivated. And so patients may experience palpitations, they may experience dizziness and lightheadedness, as well as excessive sweating and certainly temperature dysregulation. They may notice this in their GI system as well, where they have problems with their digestive tract where they cannot digest properly. And so they may have lots of bloating or constipation, or even too fast motility where they have diarrhea. And then the third big category that I like to talk about is the immune system. So we know that long COVID is an immune problem, an immune system problem. There is overactivation of the immune system. We see this in patients reporting crashes or feeling unwell or flu-like after even the most minimal activity like brushing your teeth or combing your hair. It may show up as something called mast cell activation, where there is a lot of allergic response that you may recognize. And these symptoms are just the tip of the iceberg. There are so many things that our long COVID patients experience. And I just wanted to highlight some of these so that we had a basic understanding of how much this can affect and how much it can affect your quality of life and functionality. And so today our focus is going to be talking about how those symptoms, how that experience of long COVID actually shows up in our patients' lives and how it affects their way of life. I'll hand it back over to Grace.
Thanks so much, Nija. So here I'd like to introduce our three panelists today. They're all individuals with lived experience, some of whom have done a lot of work in advocacy for their condition. And so before we go into sort of more detailed questions, we'd like to invite each of our panelists to take a few moments and describe their journey and what brought them here today. Starting off with Kara, maybe a few points about yourself and then your story.
Hi, good morning, everybody. So I was a previously healthy 51-year-old woman before I became infected with COVID. I was very active and fit. I, walked most days, jogged once or twice a week, did Pilates, swam, loved hiking, biking, traveling, all that sort of thing. And I had gone to a conference at the end of February 2020, and it was just as COVID was, well, so we thought, hitting Canada, even though it had been here for a while before. And I came home and I got sick 11 days later, and both my friend that I had visited in Vancouver and I had both gotten sick. And at first I just had a sore throat and this weird intermittent chest tightness that came and went, sometimes at rest and sometimes with activity, headaches, and a low-grade fever. So I didn't feel that sick, but my GP wasn't sure what was going on and treated me for strep throat in the beginning and told me that I should isolate just in case. I was tested for COVID twice at that time, on day 11 and day 31 of my illness, but I never tested positive. And so that made life a little bit difficult. So I sort of went on for 14 months in no man's land, not knowing what was going on. I had a couple of months where, like I say, I wasn't that sick. And then by that summer of 2020, I was in eMERGE 5 times with symptoms of a heart attack. And that's sort of when things went very poorly for me. And I was referred to a cardiologist. And unfortunately, because I had the negative PCR test, it affected people looking outside the box. I sort of kept questioning, could I have, this long COVID that people were starting to talk about? But he kept saying no, and that my heart was normal, and that I should buy a treadmill and walk on it every day. And so I didn't know any better at that time. And so I did that, and that ended up landing me in bed for 4 months. So I was bedbound for 4 months from January until May of 2021. I was very sick, constant, intense chest pain, headaches, a low-grade fever that lasted for months and months. Having a shower was an event in my week. Like, I could barely tolerate being sitting upright, let alone walking and moving around in the house. And then I ended up being housebound for about 1.5 years. So I finally got diagnosed with long COVID in May of 2021. But still at that time, people were still learning, and internal medicine had sort of ruled out cancer and autoimmune diseases and all those nasty things. But people still weren't quite sure what to do for treatments. So it wasn't until December of 2021 that I finally started a medication to bring my heart rate down, and slowly started making improvements. So I'm now 3 3/4 years out. I'm somewhat functional now. I can drive again in the city. I still don't drive on highways. I can have an appointment and stop and pick up a few groceries and make a meal now for my family, but I still have to be really careful about pacing with my energy. Post-exertional symptom exacerbation happens when you start to feel a bit better, you do too much, and then you crash. And so that's been one of my biggest challenges, is to find out what my body can tolerate, because I can't trust it anymore. I feel good when I'm doing it, and then I crash. So that's sort of where I'm at in my journey now. I'm still not able to work, but just trying to become more functional. I'll leave it at that for now.
Thanks so much, Kara. Tracy, would you like the opportunity, or would you be able to give us a few comments about yourself and kind of the broad strokes of your journey so far?
Sure, thanks. Yeah, so before I was ill, so I have two passions in my life, reading and food. I used to work as a children's book and toy buyer, and then after that, I worked in the hospitality industry. So before I got ill, I was working as a chef, which, is a fast-paced, high-intensity kind of job, lots of physical work, lots of, mental calculations, very much on the fly, very speedy. And now I have none of those things. I became ill early. My first symptoms was mid-March 2020, and went through similar things of not being able to get care. I hadn't traveled. I didn't work in the medical field, so I wasn't eligible for any kind of testing. So I was sort of just on my own, and was told to stay home and that I would eventually get better, which I was up for. That didn't happen, unfortunately. So I think I would describe sort of my journey as becoming, my initial symptoms were quite mild. I think that people had this sort of idea that people with long COVID, you were hospitalized and something went terribly wrong, but I was at home and, it was not great. But I sort of managed. I wasn't hospitalized. They didn't need to call an ambulance. And that sort of became the beginning of a very peculiar decline, where now here in sort of coming up to my fourth year, creeping up to the fourth year, I would say that my condition now is more stable but less functional than I was in the first 2 years. The first 2 years were just a cascade of event after event after event, where I didn't initially lose my sense of taste and smell. It didn't happen until a few weeks after my infection. And I realized immediately that it was a neurological issue, not like a you're stuffed up issue. It was like the signals from this part of my body to my brain are not getting through. It was like a light switch that went off. And that was sort of when it became, because I'd been in denial up until that point. I was like, yeah, you'll be fine. You'll get better. You'll get better. Certainly in the world of restaurants, there's a sort of machismo that goes along with it. People don't get sick. You don't call in sick. You work through whatever's happening. Like, I quite literally put an oyster knife through the middle of my hand, wrapped it in saran wrap, and kept working, because that's the ethos of the industry. Not because it's a good idea. I wouldn't recommend it. But it's just, that's sort of the way it goes. So it's like, I'm definitely going to wake up and get better and be back at work in no time. So yeah, I lost my sense of taste and smell. And then it wasn't until after that I started having cardiac issues. Started realizing that I was having, allergic reactions to things. And so it was about a year of symptom after symptom after symptom coming up, where, I would have it was an extremely boring time, punctuated by sheer terror. It was like, oh my God, I can't do anything. I can't do anything. I can't do anything. What's this new horrific thing that's happening to me? And then sort of back down. So now I'm pretty much just stuck in the boring part, where I'm mostly used to the things that go wrong. Occasionally something slightly new might happen. Like I said, it's a cascade of events. It's not like you got sick and you stayed sick. You got sick, and then a bunch of really peculiar things start happening in your body, where things that were absolutely fine before, I didn't even have a family doctor, because I was just walking around in this haze of wellness that I thought was, I didn't have to worry about, which people, obviously you're supposed to be on top of those things, but I was goofy. And now I don't have much in the way of function. Like, this is going to be my 2 or 3 days. You know, I rested yesterday. I'll rest as soon as I'm done this. This is my big night out. This is my Friday night and Saturday night all rolled into one, just coming here to speak for a couple of hours. I have very little function outside of meeting my basic needs. I can eat about 5 to 7 things on a good day, without having a negative reaction to them. And every now and then I try things to see, because it's really boring eating the same 5 things all the time. So in the summer I tried blueberries, disaster. Apple, disaster. 2 weeks ago I tried bananas. I'm never eating bananas again. So yeah, I've had my skin peel off. I've been covered in hives. My legs feel like they're burnt. You know, like I've taken too hot of a bath pretty much all the time. It took me a very long time to get anyone to take me seriously. The first cardiologist I spoke to sort of accused me of having like a drug problem I wasn't dealing with. And like, yeah, there's something wrong with your heart, but you know, if you're not going to be honest with us, we can't help you. I don't drink coffee. I've gone through a very difficult time trying to access any kind of care. To this day, I don't have any kind of team that's working to, you know, make sure that there's no monitoring of my condition. It's just sort of like once a year I get to see a cardiologist, and once every 6 months I might see a neurologist, and neither of them have much to offer. I haven't been able to see an allergist or anybody who deals with MCAS, so I don't know, with the lack of function that I have and being a person that's alone and not having anyone to advocate for me, I don't know if things could be better, but I don't have the energy or wherewithal to navigate that. I don't know if I've talked too much. I apologize. But that's sort of where I'm at, I guess.
Thanks so much, Tracy, for that. And Legia, if you feel up for it, a couple of sentences about yourself and what brought you to where you are today.
Yeah. So I had, in some ways, similar experiences to both Tracy and Kara, in that things weren't really clear. It wasn't really clear what was happening when I first got long COVID. So I was in my early 40s. I'm a parent. I, was pretty active. I wasn't as active as Kara. But my child had what we thought might be COVID in very early April of 2020. But because, no healthcare workers in our family, no travel, it wasn't possible to get a COVID test at all. So we just kind of assumed that maybe that was what had happened, but just went on with our lives. Neither my partner nor I got sick. And 8.5 months later, I started to get really sick with long COVID, but I didn't realize it was long COVID at the time. So I spent the next 4 months bedridden and trying to figure out what was going on, having test after test after test. My family doctor was luckily really kind and wanted to help figure out what was going on, which is not the case for a lot of people with long COVID. And then I ended up figuring it out because my first vaccine shot in April of 2021, I improved overnight. And within 2 weeks, I was as healthy as I'd been in December 2020, right before falling ill. But that didn't last. I had a great improvement with the first shot and then some improvement with the second shot. But I also just launched myself back into my normal life. And now I know that was not the thing to do. I kind of managed to get along until the end of 2020. I was seeing a real decline. I had been able to walk in the summer and the fall of 2021. But by December of 2021, I had to use an electric scooter to go a couple blocks to go to take my kid to the park. And then right after New Year's in 2022, in the middle of Omicron, I had an urgent medical appointment and ended up with COVID, but I didn't realize it. So I have never had a positive COVID test. But that time, it took me several weeks to figure out what was happening. I was being seen by a long COVID clinic, which was a mixed bag. All of the therapists, the physio, the occupational therapist, the speech and language pathologist, the social worker were amazing. They were really dedicated. They did so much research on long COVID. But it was the physician who was tasked to that clinic who did not know a whole lot about long COVID. She actually was the one who said, oh, maybe you've had COVID again. And then it all started to click. I had weeks of night sweats, which never had before. My hair had started to fall out again. And so I have not improved much since then. I now, I have POTS, which is a form of dysautonomia. So if I stand up, my heart rate goes up, my blood pressure goes down, I get dizzy, lightheaded, short of breath. So I use a wheelchair to leave home. I'm not able to leave home very often. Sometimes it's weeks or months that I can't leave home. Sometimes in the warmer months, maybe I can go out once a week, but then that will be like an hour taking my kid to the park, and then I'll be in bed for the next 2 days. I am incredibly, incredibly lucky, and I wish that my partner was here right this second to hear it. But I have a partner who takes care of almost all of my needs. He cooks me every single meal. He helps me with bathing. He picks everything up. We both homeschool our child. So I live a very isolated life. I spend the vast majority of my life inside, like 99% of my time inside my apartment. And we still don't go anywhere inside other than urgent medical appointments. And I say urgent because there are medical needs that I have that I can't deal with because I'm afraid of getting COVID. And we'll talk about this later, but becoming physically disabled by long COVID has really launched me into disability justice, and the main avenue in which I've had to deal with fighting for my own rights is in healthcare and access to healthcare safely as a disabled person.
Thank you, all three of you. Those are profound stories. I know we're going to continue to hear more about your individual experiences. What we're going to now do is we're going to pivot into some specific questions around rights, around, as Leisha just alluded to, access and disability rights. And when we were preparing for this talk, we recognized that there are so many different avenues that we could go in because long COVID does affect so many different aspects of your life. But I think the first thing that we want to maybe talk about, because it's already come up in all three of your narratives, is experiencing and navigating and accessing healthcare. So maybe I'll start with Kara, and if it's okay, we'll just kind of do a round table. So Kara, what was your experience in navigating accessing healthcare? And maybe you can allude to some of the good, bad, and ugly, if there was any good. I know that there's bad and ugly, but
yeah. So yeah, what I didn't mention in my introduction is I am a healthcare worker. I am a pediatric physical therapist, and I've worked in healthcare for 32 years. So I'll start out with the good. So because I was a healthcare worker, I was fortunate enough to have access to quick testing. The unfortunate part was that 30% of us don't test positive for COVID, for people who have long COVID. But I have an amazing family physician, and she knew me from before, and she knew that I wouldn't be making this kind of stuff up, and took me very seriously as to what was going on. But she just didn't know what else to do with me and what else to test. And I live in Edmonton, and at that time, Grace and her team had started the Edmonton Long COVID Clinic. But unfortunately, at that point, the criteria was that you had to have a positive PCR test. So she couldn't refer me there. And so then that's when she referred me to that first cardiologist. And, you know, with living and working in the healthcare system for 32 years, like you would think that I know how to access things. But even as a healthcare worker, it was difficult to access things. And I found it very frustrating working with this first cardiologist. Unfortunately, or I guess fortunately, that was my only negative experience. Everybody else has been amazing. But, you know, I sort of brought up things like, you know, do you think this could be my autonomic nervous system? And he's like, no, you didn't test positive for COVID. And he just continued to do stress test after stress test where I had like intense chest pain and my head felt like it was going to explode. And, you know, I could barely go 5 minutes and he would tell me that I was normal. And I'm like, no, like I used to jog like 5 kilometers. This is not normal for me. And I found it, not that I expected special treatment, but I mean, I do have some knowledge. And when I asked him, you know, what was sort of the physiological reasoning of how, you know, walking on a treadmill would help my heart to heal, because at that point I'd been diagnosed with viral pericarditis, which is inflammation of the lining around the heart. And he said, well, it's exercise. And exercise is good for you. And like, I'm a physical therapist. I've been prescribing exercise for 32 years. Like, I know it's good for you, but I was looking for something a little bit deeper. So that was really challenging. And I feel like, you know, him not looking outside the box really hampered me with getting the care that I needed. And so it wasn't until 2021 that I discovered a physio in the province who was working with people with long COVID. And, you know, I organized a Zoom consult with her and she was saying, well, you know, it does look like, you know, you might have POTS and, you know, you're certainly sounding like some of the people that I'm seeing with long COVID. And through her, I ended up taking a course about long COVID and met another physician who had opened up a clinic in Edmonton that you didn't have to have a positive test with. And so I ended up being referred to him, and he was hugely helpful, very understanding, and just the validation of getting a diagnosis after 14 months was so important. And I just will forever be grateful for his support, helping guide me into getting service and treatment for long COVID. And, you know, even though it's a new illness and we're all just learning, like he was very upfront about, you know, what he knew and what he didn't know. And when I went to emergency all those times, like the emergency staff were amazing. And they would always say, like, if you have any different symptoms with your heart, please come in. You're not wasting our time. So I was really appreciative of all of that. And, you know, I've gradually built my own team around me, you know, finding a psychologist and finding an occupational therapist and having the physio and that sort of thing. And they have all been super supportive. And I think the most important thing is that this is a new illness and, you know, we don't know a whole lot about it, but we're all learning together. So I've had very positive experiences. And then that physician moved to Edmonton and I started seeing Dr. Bakshi, and she is wonderful as well and has been super supportive to me as I've been navigating through this illness. So I'm fortunate that I've just had the one experience, but I know so many people that have been dismissed and told they need anti-anxiety medication. And yeah, it's just very worrisome for me, for people out there, because I know that I'm very lucky for the care that I have received.
Thank you, Karen. I think you bring up some really excellent points in that as a healthcare worker, we do have a little bit more kind of inside knowledge. We understand a little bit how the system works. And even then, it can be very challenging to know where to go. And I think particularly for all three of you, as you experienced these symptoms very early on in the pandemic, that's also an important factor to bring up, because those who are getting the diagnosis of long COVID now, or who may have had COVID earlier this year, it's a very different experience than what all three of you have had to live through, where the medical community didn't know, didn't understand, didn't want to understand in a lot of instances. And as you alluded to, Kara, we're kind of learning as we go. And there's not many of us, when I say us, I mean healthcare workers that are treating or working with long COVID patients still to this day. We're very fortunate in Alberta and in Edmonton to see that. Leisha.
I actually want to give the counterpoint to what you just said. I'm a journalist, and I've been doing a lot of reporting this past year, specifically on women of color in the US with long COVID. But I know that there are many, many, many parallels between the US and Canada. And what I hear time after time is that when people do actually identify their symptoms as long COVID, their doctors ignore them. And so I think, you know, what Kara has experienced and what you bring to your patients is amazing. I don't think there's any doctor in Toronto doing what you're doing, Nija. There were 2 long COVID clinics in Toronto. They have both closed with absolutely no media attention to this within the past few months. And so, yeah, definitely, you know, I think the more common experience that people have is not being believed, being told that they have anxiety, seeing physicians who should be knowledgeable, like cardiologists, and you know, when they clearly have dysautonomia, and being told that, again, anxiety, excuse me, and those are the people who can identify their symptoms. I don't want to talk too much about it because my story hasn't come out yet, but I'm finishing a really big story on Latinos with long COVID in the U.S. And what I heard mostly was people not being able to identify their own symptoms, partially because of denial, partially because of community stigma. But their physicians are most certainly not identifying their symptoms the vast majority of the time. And this is a huge problem. I also want to, you know, not to be, sorry, argumentative, but I also wanted to give a counterpoint to Kara's point about long COVID being a new illness. You know, in a lot of ways, it isn't a new illness. It's so similar to myalgic encephalomyelitis or chronic fatigue syndrome. And I think, you know, a huge point that people with ME/CFS, which is how it's abbreviated to, have brought up over and over again, that if ME/CFS, which like long COVID largely affects women and people assigned female at birth, if it had been researched in the decades that it's been known to exist, and likely centuries, we would not be where we are now. I actually can't find. So there is definitely a lack of physician awareness about it. We all know that there's a huge lack of public health education or attention to it so that people can figure it out themselves. And, you know, doctors that should have known about things like ME/CFS don't, and then don't know about long COVID.
Now, those are great points, Leisha. And Tracy, you wanted to comment as well?
Yeah, I just wanted to add to what Leisha said, because the parallels between, you know, the US and Canada are, I mean, it's the same place. There's a couple of there's some manners that are slightly different, you know, some mannerisms, but the experience that I had trying to access care was very much affected by racism. Like, I can give you, you know, like 5 solid examples of times when there was no other explanation for the lack of care and dismissiveness that I ran up against. And, you know, I've never been able to access the long COVID clinics that did exist. I've, again, never had a treatment team. I have been blocked. I've literally had to go on letter writing campaigns to try to access appropriate specialists, and was blocked on 2 different occasions by internists and emergency room doctors. It is definitely put me on like sort of my back foot. I do believe that, you know, with earlier intervention and a little more support, I might have more function now than I do. And I know that I'm not alone. I know that, you know, race and class do like this sort of fantasy of this wonderful utopian healthcare system. It's just that it's a fantasy. You know, where you live and what you look like make a huge difference in the care that you're going to be able to get. You know, so, and yeah, it's been an uphill battle. And as far as, I mean, obviously ME/CFS and post-viral illnesses have been ignored for a century for sure, that we know of, you know, documented, and then, you know, people were just thrown into institutions or left to die, honestly, because I feel like when we talk about sort of the overarching sort of look at like, okay, well, this is like a middle-class white woman's disease, right? So it's like, we know that it primarily affects women, and that being middle class and up is the only way that you're going to have yourself recognized. It's the only way that you're going to have access and to be able to afford to continue seeking treatment and I can't think of the word, my brain is not working, but a diagnosis, right? And so people just go without and they die. They wither away and they don't exist anymore. And so it's not because there aren't other people out there, it's because they don't have access to care. And as far as, you know, saying, okay, it's new or it's not new, you can argue that or not. But what I don't understand is sort of the contempt that I see a lot of doctors have for their patients. That if I come to you and I say that I'm not feeling well, your first instinct shouldn't be to dismiss somebody. They came to you for a reason. They didn't come because they need, you know, they wanted an extra day off from work. They're not okay. And sorry, I'm getting emotional. I just don't understand why it's so hard to say, okay, I don't know what's going on, instead of you're hysterical. I don't need to listen to you. People go to doctors for the same, you know, they go to a restaurant, they go, I'm hungry, so I go to the restaurant. I'm sick, I go to a doctor. But people don't, you know, if I was, and sorry, I'm making restaurant analogies, but it's like when people come in, I'm just like, oh, that's definitely not what you want, or you don't like that, or you don't have that allergy, or whatever. I'm just going to give the customer what it is that they ask for, because it makes me happy to make people happy. They're there for the service. And I know that it's like, you know, well, it's a sort of capitalist, but it doesn't, I don't understand why there seems to be, and I'm not new to this idea, this adversarial relationship that doctors have with their patients. I don't understand where it comes from or who it serves.
I agree with you. I'll make a quick comment and then I'll go to Kara there. I think both Leisha and Tracy brought up fantastic points. I think there's so much intersectionality that we can talk about with long COVID, with ME/CFS, with post-viral syndrome. And I agree with both of you that this is not a new illness. This is not a new pathophysiology. This is one that is brought into the forefront by the sheer volume of people that are affected by it. I think the most recent statistics were something like 15%. And I'm sure that's actually a lower number, but 15% of people with acute COVID go on to experience long COVID. But there's so much to that statistic alone, right? It is health literacy. What is your access to understanding your symptoms? Do you even have internet, right? Do you have the ability to go online and look at what your symptoms are? And then we talk about race and class. We know that the immigrant population is not accurately reflected in any of the long COVID research, because many patients can't afford to take time off work to go to a physician, to a specialist, to a treatment plan. They may not even have access to family physicians. Forget family physicians that recognizes as not even having access to that family physician. So there's so many layers that tells us we don't even understand fully the scope of long COVID. All three of you are very passionate, outspoken about this, and I really appreciate that. But there's so many people that don't have that voice that we are not even able to represent. Kara, and then we'll go to Tracy.
Yeah, no, I was just going to comment. I 100% agree with Leisha and Tracy, and I know that I am very lucky in the service that I was able to access. I just wanted to bring up a few points. I think it's important for people to know that over 50% of people with long COVID are diagnosed with ME/CFS, myalgic encephalomyelitis chronic fatigue syndrome, which basically just means really crappy post-viral illness that leaves you with all these disabilities, you know, affecting many organs in your body. And the other point that I wanted to bring up is that I know I'm really lucky in Edmonton that we still have a long COVID clinic and physicians that are seeing people with long COVID. I know both of you talked about how the clinics closed down in Toronto. The clinics in BC closed. I think they're still virtual, but there's been lots of discussion amongst people in BC that they can't access service. And then I don't think Saskatchewan or Manitoba ever got access to any long COVID clinics. And I know the same for New Brunswick, because I'm involved with a number of different long COVID things and I've met people from different provinces. And so there is very little across the country. And I just feel there needs to be so much more knowledge and advocacy for consistent long COVID care across the country so that everybody can access the care that they need and not be dismissed when they go to their physician and say, I'm having these issues, and not being told that they need anxiety medications or that they have a drug problem. And I was going to say, you sort of said it, Nisha, but yeah, I really worry about these people who don't speak English as a first language or aren't able to access a family physician, or are homeless and are just trying to figure out, what they're going to be able to eat in that week. So there's so many people out there that aren't accessing care, and I think our statistics are swayed way less than what they actually are, because there's so many people out there that I hear who haven't been able to access any service at all.
Thank you for that, Kara. We'll go to Tracy and then to Leisha.
Sorry, I'm just gonna, yeah. And the other thing that I just talking about access and care, if you happen to luck into something, some doctor, some assistant, you manage to get some kind of diagnosis. This is something obviously I experienced, where there's certainly service industry, hospitality workers. There's lots and lots and lots of people who don't have supplementary insurance in this country. And so when I talk to my American friends, they're like, well, I can't believe, like they assume that when we talk about universal healthcare, that it's universal, and it's not even close. But yeah, so it's sort of like, okay, so I have a prescription for this, and this, and then I pay for it. How, if you're working a minimum wage job, if you're working any kind of typically like front-facing service work or front-facing customer service work, you're not going to have any kind of backup. There's no plan there for you. So if you do manage to get some kind of treatment plan going on, then there's no way to pay for it. And I wanted to talk about something else as well, which is people who are a couple of different things here. People who we're sort of talking about this and coming up from a place of like, I was very healthy and I was working and I was doing this, and then I got COVID. But there are people who are already disabled that got COVID and developed long COVID. There are people who are institutionalized, whether like mental health institutions, long-term care homes, prisons, that got COVID and developed long COVID and are not receiving any care, have been like dismissed as like, well, you're already like mentally unwell, I don't have to listen to you. You're incarcerated, I don't have to listen to you. You're just getting old, I don't have to listen to you. Or you're already disabled, I don't have to listen to you. There's a huge swath of people that are not being included in this, just outside of like, I can't work anymore. Like, we're assuming a level playing field again where there isn't one. And yeah. So outside of language barriers, there are, I think, probably a lot of people in carceral situations that are not getting the care they deserve. Sorry, I just want to get that in before I forgot it.
Leisha, go ahead.
Yeah. Things that both Kara and Tracy were talking about made me think about how the fight for human rights for people with long COVID, and also people with disabilities just en masse, it's ironic and horrifying how hampered we are in our fight for human rights as a core of people, just by what we're having to do to survive. Most of us are really ill, and use those of us who are advocates use energy and time that we don't really have. I know my health would probably be a bit better if I didn't work, which I need to part-time, and also if I didn't do advocacy, but I feel like I have to. So what Kara was first talking about, the clinics closing in BC and in Manitoba and all of these places made me think, how many people, which yesterday I think I read a stat of like 1.1 million people with long COVID in Canada, which I absolutely don't believe. If if something like 94% of Canadians have had COVID, then we would be looking at more like 6 million Canadians at least, sorry, who have long COVID. So, clinics are closing down, people are without care, but it's so hard for us to get anywhere because we're so sick. We're all having to reinvent the wheel. This is what I talk about when, in long COVID forums online, for example, whenever somebody gets sick, it's like having to reinvent the wheel all over again because they have to figure out, how do I figure out what's wrong with me? What is this symptom? Where do I find a doctor? So there's all of that. And then also the other type of trying to survive is working when you're sick and you can't afford to do anything else besides work. And you don't have any time. Like Tracy's saying, you don't even have time to go to the doctor, but you certainly don't have time to organize. And so, it's awful that that's the case. And it makes me angry because it's like, I feel like that limitation has been imposed on us, not only by COVID, but also the lack of COVID precautions over the past years. And then all of these barriers that we're having to fight against, lack of income, lack of health, lack of energy, lack of anything. And how are we as a large group of people going to get what we need? Because nobody's going to give it to us unless we scream and scratch and fight for it. And that just makes me really upset.
Thanks so much for that, Legia. And I think reflecting upon the answers that all three of our panelists has provided, I think one of the many themes that's pervasive throughout everyone's story is the fact that so much of your energy and attention has to be devoted to looking for care and advocating for yourself to access to care, that what time does it leave you in terms of work? And many of you have also pointed out that employment is important for you to survive and have an income and be able to live. And so with the chronic condition in particular, how have that impacted your experience navigating employment specifically, such as returning to work or modification of duties, etc.? So maybe start off with Kara.
Sure. So, as I said, I am a pediatric physical therapist and used to work in a rehab hospital and a children's hospital. And it took a long time for me to accept that I wasn't capable of doing everything that I wanted to do. And I kept thinking, oh, I'll be back to work in a few weeks. Oh, I'll be back to work, in a few months. And the timeline kept moving and moving and moving. I finally did try to go back to work in February of this year, 2023. And with Alberta Health Services, they wouldn't accept you trying an hour or two. So I had to work a minimum of 4 hours. And so my occupational therapist had written a very detailed, slow, gradual return to work. There's an organization called Realize, which is for people with disabilities, and they had done a really nice document of how people with long COVID need a really slow, gradual reintroduction to work. And so we had shared that with my employer. And so I went back to work just for a 4-hour shift once a week. And I did that for a month. And all I was doing was sitting at the front of the hospital doing the door screening and asking people to put on a mask and directing them where to go. It wasn't physically demanding. I was sitting at a table. It wasn't stressful. I didn't run into anybody harassing me about wearing a mask. People were actually quite nice about it. I was happy to be back in the hospital and seeing some of my colleagues, even though I couldn't do my traditional, more physical role. But I only lasted for 5 weeks. After the 4 weeks of one shift a month or one shift a week, I went up to 2 4-hour shifts in a week. And then I ended up crashing and had pretty intense symptoms and back in bed for most of the next month. And it's been really hard to come to a point to accept that I need to let my job go, because they'll only hold my job for a couple of years, and I've reached that point where they won't hold it anymore. But I've come to the point where I realize that I have to let it go, because whatever little bit of energy I have, I want to be with my family and friends, and I know that I'm very fortunate that I have some disability insurance. Obviously, I'm not making the same income that I made before. I'm hoping that I'll continue to get that. I still don't know at this point. I also recognize I'm very fortunate that I have a spouse who has a job and an income, so it has impacted our family income, but I am not going without any support, as you know, somebody like Tracy living on their own, and a few of my other friends with long COVID that are living on their own and were self-employed before or don't have disability insurance. But it's really hard when you've worked all your life, and that's part of your identity, and it has definitely taken some change in mindset to recognize that my identity is not only with what I do for work, and I would much rather try and advocate for people with long COVID with the little bit of energy that I have as well. So I have come to terms with letting my job go.
Thanks so much for that. And it sounds like your experience and your journey has really not only impacted, your physical health, but also how you view yourself, and your sense of identity is very much so been disrupted and impacted. Tracy, since you were brought up, do you feel comfortable sharing a bit your thoughts on this topic regarding returning to work, employment, and perhaps challenges that you might have encountered?
I mean, that's not an option for me. I can't work. There is no work for me to return to. I mean, honestly, my job was, it's not you can't do it remotely, and you can't do it for a couple hours a day. Even with, I feel, I feel like I have been doing sort of low grade advocacy work this entire time. I do volunteer my time with as a patient partner. I have a side project called Birch that I work on that's focusing on making infographics for people, primarily Black and Indigenous people, around COVID and what can happen to you with COVID infection. I can maybe guarantee myself 2 hours a week of really sort of getting in and doing stuff without making myself incredibly ill. Like, if I look at, this is a long day for me. I don't have anything in the way of support. So I've been sort of living off of charity and well wishes for the last a few years. And typically in Canada, if you apply for government disability support, you're going to be denied like 2 or 3 times. at least before you can access those. In Ontario, where I live, you can be if you can. If you have no savings, you can access sort of the interim program of Ontario Works, which is like about $700 a month to lawn. So out of that $700 a month, you would have to pay for housing, food, phone, because internet, because doctors do not use carrier pigeons. You'd have to pay for all of your medications, and it's absolutely impossible. Like, it's impossible to live on it. You cannot. Apartments in Ontario, because I was like I need to leave the city because I can't afford to live here. But it's like Owen Sound, Barrie, the average apartment is $2,000 a month. So if you're getting $700 a month, there's literally absolutely nowhere to live. And if you end up on the street, they will take away your housing portion, so you'll end up getting $300 a month. So you have to try to figure out a way to get off of the street with half of the money that is already, probably. So it's half of what you would get if you were approved for disability, which again takes years and is still 50% below the poverty line, and that is across Canada. So you can't live on it. And for this sort of idea, well, you just go get a job. But when you have an energy limiting condition, if you have a physically limiting condition that it precludes you from working, you will just get sicker and sicker and sicker until you expire, or you've made. We do not. We spend less in Canada on disability supports in the United States. We're almost at the bottom of the list when globally speaking on what we spend. We spend, I think, about like 60%. I'm going to say 40% less per person on supports than the United States does. And so we point at them and go, look at how terrible things are there. Where actually people I know who, are disabled in the United States, have stable housing. No, it's not great. It's not good. Please, I'm not trying to say that. There are no food stamps here. There's no pharmacare here. And, there's a lot of medical procedures that are denied to people based on, again, what they look like and where they live. So we have a profoundly inequitable system here. And we should be, as a country that is so wealthy and has so few people in it, just profoundly ashamed.
Thanks so much for that. Oh, sorry.
No, I was just gonna jump in. I'm American. I'm hoping to become a Canadian citizen soon, but that is really, really shocking to me. It is really shocking. I knew that OSDP was really low, but I had no idea the low level at which Canada, my mind is just blown. And this points out again, so what's going to happen? How can there be a movement to change this if truly and honestly, I believe the only people who will care about this are disabled people and their families? Because something that I've come to realize, very, very quickly after is that almost nobody else cares about us, So in terms of work for me, I'm self-employed. When I got sick, I was on a parental leave, which was totally unpaid. Because of my spouse's income, I can't qualify for disability benefits in Canada or the US. And I probably never will because of being self-employed, because you have to put in a certain amount of hours, for example, into Social Security. And I'm not exactly sure how it works in Canada, but that's not going to be something that I'm ever going to be able to access. I question a lot my choice to go back to work. I was really sick in April of last year and somehow decided that going back to work was a good idea. I have no idea, no, I do know. I mean, I was really depressed. I was so sick and it was really scary. And my my brain wasn't working, and I hadn't worked for several years because of taking care of my kid, which was, those were the best years of my life. But still, I got offered a part-time job, and it was like, okay, this is something, and it really did help my mental health. It was not good for my physical health at all. And it was too many hours a week, and it was structured hours. But yeah, this is something that I'm going to battle with for the rest of my life. How much can I work? I feel really lucky to have decided to be freelance way before any of this happened, because I can be really picky and choosy about work that I take on. And for example, hopefully in about a week or so, I'm going to take the rest of the month of December off. I'm not going to work at all. When I don't feel well, I take days off. Sometimes I have to take weeks off when I don't feel well. And generally I've been able to manage that, but I have no retirement savings, and then once I started working, it's like, now I can't stop, because my partner and I just bought our first home right before I got reinfected, and interest rates went up so high, and we're both immigrants, and we support my partner's family abroad, and we, with just his income, we barely scraped by. So now with my income, it's like it has to go towards my future care. And my kid spent a lot of their life having me not working, and says, "Mama, I don't want you to work," because what happens is I use my very, very limited energy for work, and then I don't have energy left over for my kid. But the thing is, I tell my kid, if I don't work now, you're gonna have to, when you're an adult, you're gonna have to pay for everything for me and for your dad. And I don't know how much it's going to cost to take care of me when I get older, and I have to work now, even though it's detrimental to my health. Another thing I wanted to mention, having a spouse who's working, it feels often like a very tenuous thing, because even though my partner has a very stable job, we have had intense human rights battles with his employer so that he can work from home. He has the under Ontario human rights law, he has the right to accommodation, but because of family status, because of being my caregiver, and we have had to pay what's going to end up being thousands of dollars to a lawyer to protect that, because if we didn't protect it, he would have to go back to work in person, and without fail, he would get sick, because every single semester, several of his colleagues are sick. So it just feels like, work sometimes brings a lot of joy to my life, and it takes more than that out of me. And it feels like a privilege, but it also feels like a burden. And having a partner who has a stable income feels like a privilege, and it also feels like it could just be taken away at any minute, Like, my family has been the most careful about COVID of anybody that we've known during the whole pandemic. And yet I got COVID twice, for the first year of the pandemic, I was the one who did everything out in public because my partner has asthma. And so it's like, with all of that happening, and me having gotten sick, and the idea of him going to work in person is just terrifying. Sorry, I'm rambling a little bit, but work is a very loaded subject.
Absolutely. And, I wanted to follow up on something that Tracy has mentioned before my screen decided to do something funny. But just to also broaden and highlight the fact that a lot of the disability insurance and the disability claims require a physician documentation. And so specifically for patients who don't have access to primary care, then that becomes a big, big barrier to accessing financial supports as well. But as Leisha also pointed out, even though she is working part-time, and so she isn't in the same sort of category of looking at these sort of financial assistance, it's still not much rosier in terms of her experience, and there's definitely challenges that is inherent, it sounds like, both for herself. And the other, I think, major area to highlight is that of caretaker and caretaker burnout and caretaker challenges. Before we kind of move on, to the last bit, perhaps,
I just want to say one thing about that. I think something that that isn't talked about really at all is the huge burden on people who are caring for long haulers. It's been in a little less than a month. It will have been 3 years that I've been sick. And my partner's had like 2 days where he just kind of has to stay in bed because he's so overwhelmed with everything. But that's 2 days in 3 years. And other than that, he cannot stop. And there are a lot of people, and there will be even more people. And that's not even considering the long haulers who are caring for other long haulers, their spouses or their children or their parents. So I think that's, a problem that will only continue to worsen.
Kara?
Yeah, I'll just comment on that as well. It definitely impacts the whole family unit, having somebody living with long COVID. At the point in 2021 when I was bedbound, my husband is a principal in a school, and in the middle of the pandemic, it was extremely stressful for teachers and administrators in schools. And at the same time as he was caring for me and us not knowing what was going on, we had to put my mother into long-term care, and his mother was diagnosed with a brain tumor. And so it was a whole lot of stress going on in that spring and summer of 2021. And so my husband then developed his own medical condition, I think, because he was so stressed. He was just tensing all the time and ended up developing this tinnitus, ear ringing in his ears. And it was so bad that he actually had to go on medical leave for 4 months. And so it's definitely difficult on the partners who are caring for their partners with long COVID. And then it impacts the children, if you have children, in many different ways. It's very difficult, for my friends with long COVID who have young children, the guilt of not being able to care for their young children. One of my friends couldn't read her little girl a bedtime story for the first year and a half that she was sick. And then it's really difficult with kids that are teenagers and in high school. I was dealing with one in high school and one in early university, and I was terrified that if I got COVID again, that I would die because my heart was so impacted. And, they wanted to see their friends and do things. And so we had many arguments about, whether they could see people outside of our family unit at that time, because at that point you weren't allowed to mix with other people, and it caused a tremendous amount of stress in our family until things went on long enough that they finally started to get it and understood how delicate my health was at that time. And then as I've gotten a little bit better, I've been able to allow them to extend their boundaries a bit more. And then, of course, they are back in school, and so they're around lots of people, which always is scary for me. But I think no matter what age the children are, or the spouse situation, it's just stressful all the way around for the whole family unit.
Thank you for those comments. And so looking at the time, we've got about 20 more minutes. I want to focus a little bit on our calls to action. And I think as all of you listening to this can hear from our panels, there are so many different things that needs to be done in the form of advocacy for long COVID, for disability. And one of the things that maybe I'll quickly highlight, then I'll bring on Palace back in, is around one of the things that Tracy alluded to of the antagonism and the barriers that patients feel when they access care and they're talking to their family physicians. There is a very well-known and research and evidence-based information around stigma around invisible illness. And we're not just talking about long COVID now, we're talking about fibromyalgia, we're talking about ME/CFS, PODS, EDS. We're talking about things that from the outward you can't see. Somebody might look at this, even at this presentation, say, well, everybody looks well on this presentation. They're talking okay. And so that idea of invisible illness is a very real thing. And when we talk about stigma, I'm not just talking about stigma to the general public. We're talking about stigma within healthcare and stigma within our own colleagues. And so the biggest call to action that I think that I want to put out there and put out into the universe is for our physician colleagues to continue to seek information and information around what is ME/CFS, what is chronic fatigue, what is fibromyalgia, what is long COVID, recognizing that these are very, very real illnesses. These are real conditions. And there is a growing body of people like myself, like Dr. Lamb, like researchers all throughout Canada that are learning about this, that are researching this and trying to bring that knowledge to application. And so this is not just something that somebody put on the internet one day and said, this is what it is. This is a very real phenomenon. And I think we have to start at the primary care level. I think we have to put this into medical education curriculum. When I was a medical student, I didn't learn about POTS. I didn't learn about dysautonomia. I learned about that in practice when patients started showing up and having these symptoms. So I think we have a long way to go in terms of education. And I think invisible illness in general needs to be a very big topic that needs to be covered in medical education. I'll bring it over to maybe our panelists to talk about their calls to action. Okay, Lygia, go ahead.
This is a lighthearted thing, but we're all, at least I think some of us are wearing makeup too today, and we did that so that we would look less, we would have less bags under our eyes. We would look less exhausted. So that's part of it, I don't know exactly what your question was, but let me just say something really quick. I think I support what you're saying so much, Nisha, because I think, even with I have a wonderful family doctor, but everything she knows about long COVID, she knows from me. And I have to do all the research and I have to find everything, which then, sometimes I tell her things just so she'll know, so it will benefit her patients. But, that's time and energy of mine that I don't get paid for. I'm not a doctor. So I think, I don't know how it works in terms of people having to do continuing ed, but figuring out a way that to make physicians do it, to make family physicians do it, because probably a lot of them don't have time to do it on their own. So sorry, I didn't mean to interrupt that. I just wanted to make that really real point that we made an effort to look less exhausted today.
I agree. And I think in the primary care crisis that you could argue that, I think family physicians will say we have so much to know, and that's very true. And that's a very fair statement. But the sheer volume of people that are being affected with disability insurances, and it's directly affecting primary care physicians with all the paperwork that they have to fill out, it actually behooves them to understand what is happening. Tracy?
I just want you to talk about what I just said, because I just feel the need to tell you that this is not attached to my head. This is a wig, because I had to shave my head early on because I'm not strong enough to brush and take care of my own hair anymore. So this lives on this chair. So anytime I have to jump on a Zoom, people don't know me or it's going to be public, this just gets popped in my head. It's my little public facing hat to make me look more presentable. And despite our best efforts, people are kinder to people that are sort of generally perceived as being attractive, and that leads into people feeling that you're more worthwhile. So it's a choice that I made. But yeah, it's definitely I did put on a little bit of makeup, and I definitely put this on for specific reasons to try and be presentable. So I just wanted to add into that.
Thank you. And so maybe what I'll do, and I'm putting you guys a little bit on the spot, so feel free to tell me if it's too much. But maybe I'll go through each one of you. We'll start with Kara. If you, because there's so much that we can ask for, but if there was one thing that you could ask for to either inform the people that are watching this, or to inform policymakers, or inform healthcare, what would it be?
Well, I think one thing that I've really been trying to advocate for is finding some way to, like you said, educate the frontline family physicians, because they're often the gatekeepers of our care and where we get referred to and who we see beyond that, if we're lucky enough to have a family physician. So yeah, what I would really appreciate is if there was more education in the medical community about long COVID, so that we don't have physicians and other healthcare providers dismissing people when they're going to them saying, I'm having all these really weird, crazy symptoms in my body. Because I know when I first started experiencing them, like, they're really bizarre, and you wouldn't believe it until you're actually experiencing them. So at this point, I think it's inexcusable for healthcare providers to not have some knowledge about long COVID. And I'm going to say two things, because my other big concern is it really bothers me how little it's discussed in the media in our province and in our country. And I feel that that is partly, if not mostly, influenced by the government. You know, people just want to pretend that COVID has gone away and it doesn't exist anymore. And they don't want to acknowledge it. And they're not saying the numbers anymore of, you know, how many people are being diagnosed with COVID every month, because they're not doing testing anymore. They're not implementing basic practices like wearing a mask when you go to the grocery store, or wearing a mask in healthcare settings. Like, you know, it was so upsetting for me when the government, you know, took away the masking in healthcare settings. I mean, that's where people are going with their chronic illnesses, not just long COVID. And for them to pick up COVID or other infections in the hospital is terrible. So I just feel like we really need to educate the healthcare profession, and we really need to educate the country as a whole through media, if we can somehow break through the barriers to say that long COVID is very real, and it's the pandemic following the pandemic. Like, this is going to be years and years of many people with invisible illness that need services.
Thank you for that. Leisha?
I just want to say, as a member of the media has immensely, I don't know, the only phrase I can think of to say is screwed the pooch, you know, has just like beyond dropped the ball. I mean, this has been intentional. This has been, you know, I've had editors say to me when I pitch stories about having long COVID, you know, nobody wants to read about COVID anymore. I tweeted about this over the weekend. You know, I pitched an op-ed to the CBC right before I got reinfected in January of 2022 about how terrified I was about how many more people were going to get long COVID because Omicron was descending. And literally the CBC said to me, we've covered this topic already. You know, so that leads into, so anyway, what I'm trying to say is that how to fix this, I don't know, but it is journalism's job to look at the truth and look at the truth that's being hidden. So if there's anybody else in the media watching, you know, there are so many stories about long COVID. I've had a really hard time placing stories about long COVID. You know, I have 3 coming out within the next month, and it was very, very hard to place all 3 of those. And I have other big stories that I would like to write that I can't. So that kind of leads into something that I wanted to say, which is that this is not going away. You know, this is what everybody at every level of society needs to think about. This is not going away. You know, decision makers, this is not going away. This is something that needs money towards it. This is something that needs education towards it. Obviously at the level of doctors, they need to learn about this because this is not going away. At the level of your average person on the street, you know, people with long COVID shouldn't be the only ones talking about long COVID. Long COVID hits, and I would say at minimum 1 in 5 people. You know, there's a range of statistics, but there have also been statistics that said it's more like 50%. At minimum 20%, so 1 in 5 people. Everybody knows more than 5 people. So you know somebody with long COVID. They're probably hiding it because they're afraid of losing their job. They're afraid of, you know, losing their housing, losing everything. If we're the only ones talking about this, nothing is going to change. And if you don't talk about it, if you don't encourage, if non-disabled people, if people who don't have long COVID don't talk about it, you know, precautions are still going to just disappear, and more people are going to get it. And we're all going to be, you know, everybody's going to be in the dystopian world that Kara and Tracy and I already live in. So my main thing is that non-disabled people and people without long COVID, please stand up for us. Stand up for accommodations, for accessibility, just because, you know, learn about ableism, learn about disability justice, because you don't want to have to learn about that when you're disabled or sick. It's harder. It takes more time. It takes more energy. And then you'll be learning about it because you can't anything that you need to access in your life. So to put it like really simply, just talk about long COVID. If you're sitting here watching this, tell people in your life that you watch this. Tell people about Tracy's story. Tell people about Kara's story. Tell people about my story. Tell people about how Nisha and Grace are treating people with long COVID, but that in most other provinces, there is not any specialized long COVID treatment. This needs to be a topic of conversation rather than just this like massive amnesia. That's not going to help anybody.
Thank you, Leisha. Tracy, anything that you want to add in terms of call to actions?
Yeah, I'm just a couple of so many. But my first and so immediate thing is a return to like proper masking in healthcare settings. Like just right off the bat, it can be done. We just, decided to drop it. There's no reason for it not to be back in place again. COVID is still spreading. It's still here. It's the 3rd leading cause of death in North America, behind all cancers and all heart disease. And there's this fantasy that we're somehow out of it, or it's okay if you are masked in the in a room, but okay in the food court in the hospital, and it doesn't make any sense to me. Those aren't good choices. So short term, yeah, bring back masks. And long term, I would just like to see like a wholesale increase in disability supports across this country. People should not happen to be living like this. And if we're going to, as we have expanded the MAID program on compassionate grounds, then people have to be able to make a real choice without coercion, without fear of like choosing this or dying in an alley somewhere. So those are my 2 big ones. And I guess, the other thing is I think about people are like, oh, doctors need to be more educated. They need to, but I mean, I feel like, when we think about jobs that are good jobs in the world, we're like, oh, being a doctor is good, being a lawyer is good, being, there's these jobs that we sort of associate with accomplishment and stability. But if people in those positions are still so overworked and so frazzled and have so little time for their patients and for their own self-care, then I feel like, how are things going to improve? If I'm like, working as a cook and I'm working like 60, 80 hours a week and I can't, afford to take time off, and people are like, well, that's just the way it is. But if doctors and lawyers and authors are in the same position, like where's the payoff? Where's the level of comfort and sort of, because if you believe that people really deserve so much, I'm not one of those people, but it's like, so where do you get, when do you get to that point of being able to say like, okay, good, I've accomplished this and now I can relax. So I worry about that because I feel like partially, yeah, there is sort of a combative relationship that doctors have with their patients. Some doctors have with a lot of their patients. There's also like a lot of stress and a lot of pressure and a lack of time to learn new things and a lack of time to explore. So, I guess, those are my little call is masks. My medium call is better disability supports. And my big call would be like the fall of capitalism. Like, I don't know, but it's like, this is not good. People are not okay. So yeah, that's my 2 cents.
Thank you so much for that, Tracy. We'll go to Legia and then we'll go to Grace.
This is really fast, but something that I don't think came up at all yet so far today, but I like to tell people when there's potentially people out there who don't know that much about long COVID, there is no treatment for long COVID. There is no cure for long COVID. So if you get long COVID, you will probably live like one of the 3 of us, and there will be no treatment, no cure. I mean, I take 2 heart medications amongst other medications now, and I still have to use a wheelchair because my heart goes on the fritz and I can't stand up. I am not aware of any research currently happening in Canada towards treatment or cure. This is not true. There is some treatment happening as part of CanCove UHN. But my understanding is, it's a fairly small study still. There's not much funding. So that's something that is hugely important too, that we need money to figure out how to treat and cure this thing, as well as ME/CFS and other associated illnesses. And if you look at, okay, well, how much money will that cost to put in the research for it? Economies are, greatly damaged by people not being able to work. So that's money too. Sorry, I'm losing my ability to talk. So.
Thanks for that, Legia. And it actually segues very nicely to a couple of comments I'd like to make to round out this discussion. One, with my research hat, is that in terms of the treatment trials out there, CIHR, the Canadian Institute of Health Research, last year had just funded a national research network. Many millions of dollars went into this, so it's a national network, and the main sort of tenet of this grant is to accelerate innovations and research and treatment. So there is lots of national research that is happening, and including from both a basic science perspective as well as randomized controlled trials. At least, the infrastructure is being built right now, and hopefully in the coming years that there will be lots more national coordinated efforts of treatment and trials. In terms of my clinical hat, the other really major thing I want to remind everybody on the call that in terms of wanting to protect yourself from getting long COVID is also immunizations. As everyone's talked about, the avoiding catching COVID in terms of mask and ventilation and what have you, it's also very important to keep in mind about the immunization side of things, especially right now with the XBB subvariant of Omicron that is circulating. The previous vaccinations don't do as well as the latest XBB vaccines, the monovalent vaccines that's been available since the fall of this year. So plug into that and encourage everyone to consider getting vaccinated to protect yourself. And in terms of advocating for all your fellow Canadians who are suffering from long COVID, I think our panelists have done a wonderful job to just get us to start thinking about what are the ways that we can put on everyone's national attention this invisible illness that they are suffering from. So with that, on behalf of Nisha, I'd like to thank all our panelists for your time and most importantly, your energy and focus and attention, because we know how much this takes out of you. And so we really, really appreciate your your participation in this. And we also would like to thank the organizers of the conference for providing space and time for us to have this discussion, meaningful discussion about disability and long COVID in particular, and how this is really a health condition that represents a lot of fundamental fight for rights in many domains. So thank you so much for your attention and listening to this panel discussion. We wish you have a great day. Take care.